Right. Thank you, Sultan. Good afternoon to you, ladies and gentlemen. Good afternoon, Mr. Chairman. The penetrating aortic ulcer, which is ulceration of the usually atherosclerotic plaque with or without intramural hematoma, could result in pseudoaneurysm or rupture. The incidence of the penetrating aortic ulcer is reported to be 2 to 10% of the acute aortic syndrome. It's usually in the descending thoracic aorta. It's more frequent than the arch, which is followed by the ascending and abdominal aorta. It's usually associated with significant comorbidities, smoking, ischemic heart disease, and COPD. The natural history is not well established. This is a retrospective study of 388 patients, which showed the location is usually in the descending, followed by abdominal and arch. It is isolated in around 58% of cases and could be associated with IMH in 15%. And it showed disease progression in around 1/4 of those patients, and also showed that symptomatic penetrating ulcers have higher incidence of progression. Couple of cases. This is a case, patient in the mid-60s, presented acutely with chest pain, was hemodynamically unstable, and obviously there is a rupture penetrating ulcer, which is close to the left subclavian artery, and was treated with a stent and embolization of the subclavian. There's another case, which is a cold case, but it is a relatively large penetrating ulcers, quite close to the origin of the left subclavian artery. The patient had lima, and the left subclavian is quite important to preserve. And this was treated with a single fenestration stented, a stent from Relay Bolton, which is trauma aortic currently. There's another case. Patient with sort of mental capacity issues, presented acutely with sepsis, with history of corrosive ingestion twice, and he has esophageal strictures, and this is penetrating ulcer just waiting to burst. Although he was hemodynamically stable, but obviously this is an infected aneurysm by definition and needs urgent treatment. It was stented with good short-term results. We're still following him up with antibiotics and see what the upper GI surgeon will decide about his esophagus. We reported retrospective analysis of 43 patients around 12 years at Imperial, with patients presented with isolated penetrating ulcer. The majority in the descending. The mean follow-up was 48 months, and less than half of them were symptomatic. 18 patients of those 43 treated with stents, except one, and you can see that the distribution in from zone 1 to 4, the majority of them. The mortality in those who treated conservatively was 24%, with mean survival of 8.2 years, while the mortality in the surgical repair was 39%, with mean survival of 7.5 years. And you can see that's a quite high mortality, and it's expected because those, as I said, they present with significant comorbidities. Systematic review published last year of 1,356 patients, half of them asymptomatic. The 30-day overall mortality was 7%, but the mortality with the symptomatic patient was higher, significantly higher, 9 versus 3. But the late mortality was similar in both symptomatic and asymptomatic. Those who were treated with endovascular has a lower mortality rate than open, but the pre-intervention was slightly higher. And the conclusion of the systematic review, that the data quality is low and heterogeneous, and there is inconsistent reporting standards in the literature and no RCTs. and concluded that endovascular should be considered first line when we decide to treat, and asymptomatic with high risk should be treated, but those with asymptomatic low risk should be followed up closely. And generally speaking, intervention is indicated with symptomatic ulcers with depth more than 10 millimeter, width more than 20 millimeter, aortic diameter more than 40, and disease progression 10 millimeter a year, or obviously if it's infected cause. Intramural hematoma is slightly different, but still within the acute aortic syndrome. It's bleeding in the wall from the vasa vasorum, may or may not associated with penetrating ulcer, may associated with intimal disruption, two types of intimal disruption, tiny one and a focal one. This is a case with multifocal intimal disruptions with pleural effusion or hemothorax and treated with a stent. This is another interesting case with initial scan showed less than 10 millimeter in one segment of the aorta, but slightly above 10 millimeter in another segment. 48-hour scan, there was increase in the diameter, but we had a quite vague clinical symptoms, and we hesitated which stent or not to stent because the symptoms were not so clear. And while waiting to have a clearer picture, he had sudden chest pain, and when we scanned, there was a type B dissection. It was stented with very good remodeling later on, but that's a good lesson to learn from. Systematic review of 500 patients showed that the tiny intimal disruption in around a third of those patients, and the risk of aortic-related events when there is a tiny aortic disruption was similar to those without the intimal disruption, but when there is focal, there was higher risk of aortic-related events. The indication, generally speaking, as a consensus that medical treatment should be first line. I'm talking about type B intramural hematoma. And it is indicated when the thickness is more than 10 millimeter or increasing, or when it is associated with multifocal intimal disruption. To conclude, ladies and gentlemen, Mr. Chairman, penetrating ulcer and IMH as part of the aortic syndrome, they have not well-established natural history. The indication to intervention is based on low to moderate level or quality data in the literature, and mainly expert consensus. And the vascular approach, generally speaking, offers better outcome than open surgery when it's indicated. Thank you.